Hello, welcome to a tutorial on gestational neoplasia. I'm Dr. Louis Hassel, and our program is made possible by some of the resources provided by the Digital Anatomic Pathology Academy through Path Presenter and the Digital Pathology Association. I'm coming to you from the University of Oklahoma Health Sciences Center, who cover my time. So our objectives in this program, as we think about what we'd like to come away with, in gestational neoplasia, there are a number of important differentials. Most of these are between neoplastic and non-neoplastic mimics, although there are some of the situations where you can be concerned about the possibility of different types of neoplasia. And most of them are associated with neoplastic states, so we'll focus on those as well. On the left-hand side here are the neoplasms or neoplastic states that we're concerned with in gestational neoplasia. Hydatidiform mole, complete and partial, the placental site trophoblastic tumor, and we've got some nice examples to show you. Epithelioid trophoblastic tumor, which is actually less frequently seen in a gestational state than in other sites such as the testis. And finally, choriocarcinoma. The differential for each of these entities is here in the right-hand column, just as a matter of reference. Hydropic abortus being the main differential consideration for complete or partial moles. PSTT can be confused with a placental site nodule or an exaggerated placental site, as well as some smooth muscle tumors, including choriocarcinoma and occasionally melanoma. Epithelioid trophoblastic tumor is most commonly mistaken for squamous cell carcinoma, but sometimes can resemble a placental site tumor. Both of these are quite rare lesions, and examples are a little bit hard to come by. And finally, choriocarcinoma is becoming less frequently encountered, but still is an important consideration in some areas of the world, and certainly needs to be distinguished from the other trophoblastic neoplasms, invasive mole, and other high-grade malignancies on occasion. So in the fully developed state, this is not a difficult diagnosis, the diagnosis of a molar pregnancy. But when we're dealing with a 10 to 12 week minimally enlarged, minimally early gestation, it can be quite a different story, and the challenges become more real. And so in much of the Western world, the early stage neoplasia is more difficult to identify. Essentially, we're dealing with the challenge of what to do about edematous villi, because each of these entities, partial mole, hydropic abortus, complete mole, can have edematous villi. In the case of hydropic abortus, there's usually no atypia, there's usually no cisterns, there's usually no trophoblastic proliferation. In the case of a complete mole, you do have cisterns in most cases. You do usually have trophoblastic atypia and some degree of proliferation, which can be florid or relatively mild. And you also have a couple of microscopic features like the absence of functioning villous vessels, and on immunohistochemistry, an absence of p53 staining in the villous stroma and cytotrophoblast. In contrast, a partial mole may occasionally have fetal tissue identified. The villi tend to be a little bit more scalloped. You can often identify functioning vessels if there's been a functioning or a fetal heartbeat. And there's usually a lower degree of atypia. Truth be told, however, finding p57 staining present and or triploidy is usually the way that we get to the diagnosis in this situation. So just again to highlight these, this differential diagnosis, p57 staining can be seen in blighted ovum and in partial mole, but is absent in complete mole. Triploidy, usually seen in partial mole, not seen in complete mole, but may occasionally be seen in a blighted ovum. So let's go to the slides and see what we can identify here. Well, here in our summary here, you see the gross features, slightly edematous villi, not much trophoblastic proliferation, and p57 imprinting is present. Clinically, these things usually present with a falling or low HCG. They may have spotting post-gestation, of course, or a spontaneous abortion. In the laboratory, we can occasionally find karyotypic abnormalities, including trisomy. In contrast, the complete hydatidiform mole has dilated cisterns, usually more gelatinous and grape-like structures in the villus, if you are able to identify them, and an absence of P57 imprinting. Usually these are patients with slightly enlarged for dates uterus. They may have abnormal spotting, and the beta HCG tends to be off the, out of the ballpark, just so high. And in consequence of that, they also tend to be more likely to experience medical complications associated with pregnancy, hyperemesis, hypertension, and so forth. And under the microscope, as we've mentioned, trophoblastic proliferation with atypia, absence of P57 staining, no fetal tissue, central cisterns, plus or minus, absence of viable vessels. So here's our digital slide illustrating this particular entity. And we can see here in this early pregnancy that we do have the development of some cisterns. Note that the trophoblastic proliferation is relatively mild, but we also have a little degree of scalloping of these villi. So scalloping is not an absolute criteria. Here, as we look a little further, we can see there's a greater degree of trophoblastic proliferation, nearly completely surrounding some of the villi, and not all of the villi are edematous with the development of cisterns. Here's one, but there are several here where we don't see that at all. But I think you can see that there is some degree of trophoblastic proliferation. Sometimes this trophoblast looks quite atypical, but in general, trophoblast looks atypical, and differentiating that from non-atypical is difficult. Here's another example. Again, we see villi here, not particularly edematous and not much in the way of cisterns, maybe a little bit of a early cistern here or some here. And as we look a little closer here at some of these areas, we see areas that might look like they're beginning to form vessels, a few of these little streaky things, but we usually would not identify red cells within the lumina of those pseudovessels. Here's another nice one here. As you see, it's not opened, the lumina is not opened, and there are no intraluminal circulating hematopoietic elements. Because there's no fetus and there's no fetal heartbeat to sustain circulation. Another example, again, we see some villi here. Apologize for the scanning difficulty in this slide. Dilated cisterns, but again, not very much trophoblastic proliferation. A little bit here in a few areas. And again, not much in the way of stromal vessels to be seen here. So this situation, this case could be a hydropic abortus, it could be a complete mole. It even, has some of the scalloping and indentations that might make you think of a partial mole. So this is where P57 staining comes in very nicely. And as we go into higher magnification on this, we see we've got some internal control staining. Some of the trophoblastic elements are staining. However, as we look at the villus, and this is where the diagnostic information is to be found, we see that there is absolutely no staining of either the stromal cells or the surface cytotrophoblast along the villus surface. You can see, some of the syncytial trophoblast, and those elements will have positive imprinting from maternal origin, but none of these paternally derived elements, the villus and the cytotrophoblast, will have evidence of nuclear staining. So what is P57 staining all about? Well, this is the entity that we're staining. It's a nuclear stain. The alleles for this P57-KIP2 gene are methylated differentially between parents, and so that's what accounts for the differences here. So the paternal gene is typically silenced through methylation and therefore not expressed. On the other hand, maternal DNA, if present, will express P57. Now, never say never, of course, because obviously there are rare instances of P57 positive complete moles and P57 negative partial moles. But these have only been discovered by molecular genotyping, and certainly in routine circumstances, the pursuit of that possibility is not either clinically or financially relevant. This gene is also called the CDKN1C gene, and it's derived from chromosome 11p. So that's the kind of cytogenetics of the lesion. Let's go on and talk about how that plays out in partial mole. So partial moles tend to look a little bit different, a little bit more proliferative, more placenta-like. They can have edematous villi with a degree of proliferation of these trophoblastic elements, but they will, as you see here, have positive P57 staining. So we'll take just a look at some of the clinical things associated with this. Again, the beta-HCG may be elevated. It's also been reported that inhibin A can be elevated in these patients, but they usually present with some sort of symptoms related to potentially missed abortion or spontaneous abortion, usually bleeding or passing tissue and those sorts of things. Attempts to use ultrasound as a screening technique have not been particularly effective, so we don't usually make the stop in radiography for that reason. And many of these will have identifiable fetal tissue, and therefore they will have villi that have functional vessels. And as I've mentioned, they're usually triploid, XXY. Other ploidies have been reported, but again, usually with a combination of maternal and paternal genes, usually with more than one paternal copy. So under the microscope, here's an example verified by cytogenetics and and immunohistochemistry. We see here an edematous villi. It's not scalloped, but we see other villi around here as well, such as this one here. Not particularly edematous, not particularly proliferative in the sense of trophoblast and so forth. Another villus here, a little bit of scallop architecture, and other villi around with variable degrees of edema and cistern formation. So you could see here that the differential would be between a hydropic abortus probably and a partial mole. Partial moles have cisterns, hydropic villi usually do not. There's not much in the way of trophoblastic proliferation. And so this is a case where immunohistochemistry may be very useful. And so here we take a look and see what we've got. And let's go down and take a look at these villi here. So we see here a few cytotrophoblastic cells along the tip of the villus that are staining. We see a few rare cells within these villi that also show staining and marking with this marker. So we can presume that this is, it does have maternal DNA, and with the degree of cistern formation, we could presume that this is a partial mole. Now we might go further on that, and we'll talk about the workup. Let's look at another example first, however. So here's another slide, lots of villi around. We see even some membranes here. And here we're starting to see this tendency or this feature of scalloping or multiple indentations in the lesion that can be associated with partial moles. But notice we're not getting really well-developed cisterns, and there's really not much trophoblastic proliferation. around the periphery of these villi. So again, we might think hydropic abortus, partial mole possibilities, and so forth. Here we can see there are some small vessels that have open lumina, even maybe an occasional hematopoietic cell within some of these lumina. So possibly functional vessels here. Maybe a thorough search would allow you to identify a few more. But the point is that this is a challenging diagnosis, and one where immunohistochemistry and other analyses can come into play. Here's our P57 stain on this particular slide. And again, we can see that here we have nice positive staining within the villus stromal cells, as well as cytotrophoblastic cells along the surface of the villus that are taking up the marker and nicely expressing it. So again, partial mole in this circumstance. Just to reiterate kind of the algorithm here, we use a P57 stain in the setting of hydropic villi without obvious fetal tissue. If it's expressed, then we're differentiating between a hydropic abortus versus a possible partial mole. And if this differential is especially difficult, then sometimes cytogenetics or ploidy analysis can be useful to see if we have actually a triploid situation that has presented. On the other hand, if the P57 stain is negative and we have the typical morphology, we would move to a diagnosis of complete mole. So that's a nice review of that. Now, why is this important? Well, obviously, the considerations for follow-up chemotherapy may be different. Follow-up HCGs may be different. And likewise, the period of contraception to avoid any confounding recurrence of a reason for a rising HCG are to be noted. Also, the recurrence risk in terms of a complete mole developing some other sort of gestational neoplasia, much higher than follow-up in a partial mole. So let's go on then to talk about an invasive or persistent mole, which essentially is a situation of following diagnosis of a mole having a persistently elevated beta HCG and potentially being able to identify molar tissue in the vessels, in the myometrium, or at distant sites, essentially becoming a metastasizing or invasive mole. I won't show you images of this because the morphology we've already covered in some detail here, but finding molar tissue in the wrong sorts of sites would allow you to make this diagnosis. So let's go on and talk about placental site nodule and exaggerated placental site. This is kind of a fun lesion. As you see here, there's a lot of pink to these lesions. We'll talk first about the placental site nodule. This tends to be a highly eosinophilic stromal focus with some admixed intermediate trophoblast in variable amounts and a very hyalinized background. That's why it's very pink. Now, of note, this can be found up to 2 and 3 decades following gestation. So oftentimes you make this diagnosis in a postmenopausal woman for some reason, and the clinician is like, huh? She's not pregnant. She hasn't even been, ovulating for, 10 years. But understand that these lesions do not regress completely, do not resolve in all situations. Immunohistochemistry, I've never had to use it, but reportedly these are CK18 and EMA positive. That may also stain with some other confusing markers, including inhibin, P63. If you're thinking squamous carcinoma, that's not going to help you, and placental lactogen, or placental alkaline phosphatase, and human placental lactogen. Now, in contrast, the exaggerated placental site, usually seen a little bit earlier, doesn't have that delayed situation, is composed of intermediate trophoblast that does have a sort of infiltrative appearance and is present at and beneath the site of implantation. But there's no necrosis, mitoses should not be seen, and you certainly should not see other trophoblastic elements. Rarely this can cause hemorrhage because of the erosion at the surface. And if there are villi present that are remaining from the gestation, they will generally appear normal or kind of necrotic, caught up in the avascularized fibrinous debris on the surface. All right, so here's a nice example of the placental site nodule. This in a curettage specimen. You can see here the nice eosinophilic hyalinized areas with interspersed, more typical endometrium. When we come into higher magnification on one of these areas, you can see that there is a degree of cellularity here. There are these cells with sort of pale pink cytoplasm and central, maybe smudgy nuclei, somewhat variable, a little bit of pleomorphism here, but not anything that really looks like confluent growth or, tumoral type of formation. This really looks more like it's sort of something that's trying to regress, becoming mummified almost, if you will. And you can see it in several fragments here, this very eosinophilic stroma. And these are the cells. You can see they have a little bit of a squamoid appearance, a little bit of sharpening cytoplasm, very pink. But these would be positive with P63 and with cytokeratin 19. The intervening endometrium tends to be relatively bland, not really proliferative yet. It's still sort of recovery phase very often, although you can get all phases because this will persist over time. Here's maybe a more cellular focus. You can see how, potentially you might be concerned that there's something here, maybe a metastasis or something like that. But if you have this in the back of your mind, usually this is a diagnosis that is fairly easy to make. Here's another example, one where it's occurring earlier. You've got some entrapped villi, and you can see this intermediate trophoblast here, a very eosinophilic tissue with a little bit of hyaline and fibrin in the midst, and may occasionally encase these old villi. Now, if the villi have all degenerated and you're left with this stuck to the endometrium, it's going to continue to exist there for years and weeks and maybe decades. Looking here at an exaggerated placental site, we see here the surface fibrin, and we would probably see, if we look here closely, that we have some villus-like structures, sort of mummified here up on the surface, entrapped in this fibrin. And then deep to it here, we have this little thin layer, slightly undulating with abundant trophoblast interspersed amidst the myometrium. Now, of course, the trophoblasts's purpose is to provide that anchor and to gain access to the vascular supply for the placenta. And so, not surprisingly, these can be distributed around or even within vessel walls and have a pseudo-invasive type of pattern. However, this is a physiological implantation site, maybe with a little bit of prominence of the trophoblastic elements here. As we go a little further, you can see here even maybe a little bit of a mass type lesion forming here. But in this situation, postpartum, this would be an exaggerated placental site, not a neoplastic lesion. So let's go on and talk about the differential for the lesion that you would be concerned about, the placental site trophoblastic tumor. This is a tumor that has malignant potential. It is usually identified in the post-gestational period and is composed of intermediate trophoblast. Now, it can have several weeks to potentially years delay in detection, and may be associated with some uterine enlargement and some hormonal symptoms such as virilization. Beta HCG levels, however, tend to be low. These lesions do not have villi, they do not have syncytial trophoblast, but these large epithelioid cells look quite atypical, and necrosis is frequently identified. Now, of note here, notice that the PLAP is negative in contrast to the exaggerated placental site or placental site nodule, but also that, other lesions, GATA3, squamoid lesion, squamoid type lesion, can be positive in these circumstances. So we'll pause here for just a second. And so here's a nice example of this lesion. I've got a couple of digital slides, and these links to these slides, which are not from Past Presenter, will be available in the comments. So as we come into higher magnification on this, notice we have sort of a diffuse pattern, and we sort of have some level of infiltration through and destruction of the myometrium. You can see the very rare residual myometrial cells here, and interspersed between them are these very large, quite atypical cells with very large nuclei, occasional multinucleate cells, and quite abundant, very eosinophilic pink cytoplasm. So you see this sort of a pattern, you'd think, oh, is this metastatic carcinoma? Is this an infiltrative neoplasm that's metastasized to the uterus? And so this is where your differential of including this possibility would come into play. Let me switch and show you another case here. Here we see a more defined mass lesion with the border, some additional areas here. And we'll come into higher magnification on this lesion. And again, we see this sort of infiltrative pattern in between and amongst the muscle fibers. A real penchant for some attraction to the vasculature, as you see here, growing around these vessels. And again, we see this image of very large epithelioid cells with rather abundant pink cytoplasm infiltrating between smooth muscle bundles and showing quite a high degree of atypia, occasional multinucleate cells, and I think you could even see potentially some mitotic type figures here in the magnification window there in the lower right. Some scattered lymphocytes can be seen, as you see here looking at this lesion. So this is a rather unusual tumor in my experience, but something that you need to be aware of and that enters into the differential for uterine masses that can occur post-gestation and may be mistaken for metastatic tumor or possibly even picomas. Now, in contrast to some of those lesions, picoma would usually not infiltrate through the myometrium in this fashion, whereas metastatic melanoma or other sort of metastatic lesions might have this kind of an appearance. So I can see this entering into the differential of a number of entities. So just to reiterate, HPL positive, GATA3 positive, they're not squamous cells, MUC4 positive, negative for PLAP. That PLAP becomes very useful. Other lesions, as I'd mentioned, that could be confused with this, and I'll just put a few of these in here for us to look at. So here's a nice example of a picoma, and as we go into higher magnification, you'll see that the similarity here is with a rather mildly pleomorphic tumor with fairly atypical nuclei and rather abundant pale eosinophilic to slightly lacy clear cytoplasm. As you can see, this is a diffuse pattern. There's no intermixed smooth muscle that you can see here. But note that, of course, in these lesions, you can have melanotic markers as well as muscle markers that could be positive and potentially create some confusion. Now, if those are all negative, then you'd want to think more of PSTT. Here's an example of another tumor that might enter into the differential here. Let's see if we can pick out what this is as we look at these cells. Again, we see this hallmark with rather abundant eosinophilic cytoplasm. and fairly large, mildly pleomorphic nuclei. Again, sheet-like growth displacing the tissue. This is a metastatic melanoma in this particular case. Oh, excuse me, that was an epithelioid smooth muscle tumor. This is the melanoma, just to reiterate the morphology for melanomas. This is not one in the uterus, but as you can see, it can have a somewhat infiltrative pattern, not as epithelioid as our epithelioid smooth muscle tumor that we just showed. So, all right, that's why we do the special stains and make notes beforehand. So let's go on and talk about epithelioid trophoblastic tumor. This is, again, an unusual lesion. As you can see, it has some of these same features, very epithelioid type cells, necrosis, nuclear pleomorphism. This is more frequently seen actually in young men. It's very rare, but it may show a mild elevation of beta-HCG. It tends to be monophasic. It has nested cell pattern with somewhat squamoid appearance, very prominent nucleoli, and this background of extracellular hyaline. Now, sometimes you'll also see this peripheral cuff of lymphocytes. Now, this lesion, in contrast to the prior lesion, is PLAP positive. It can be GATA3 and P63 positive. So again, these are not useful differentials because squamous cell carcinoma is in our differential here. But of course, in the testis, you'd be concerned about germ cell neoplasm, so SAL4, OCT4 be negative. And so fitting it into the right ballpark may be a little bit challenging. It's rare enough that I could not find a suitable slide to share with you other than that image, which I have posted on the first page there. We'll conclude with a few cases of choriocarcinoma. As you see here, this is a very malignant-looking tumor with multiple different cell types, slightly clear cells, some multinucleate cells, and a lot of associated hemorrhage in these lesions. This usually occurs proximate to a normal pregnancy or a molar pregnancy, and vaginal bleeding is the presenting symptom. It is more common in Southeast Asia and Japan, as well as in African, Asian, Native American ethnicities elsewhere. And this may be related to the prevalence of blood group A in these women, especially if they've been married to a blood group A man. These tumors typically do have beta-HCG elevation. Those are the multinucleate giant cells. And what you'd like to see, obviously, morphologically is this tripartite proliferation of syncytio, cyto, and intermediate trophoblastic cells, usually associated with extensive hemorrhage and an absence of villi. So here's one example of this lesion. This obviously metastatic to lung. You can see here the hemorrhage associated with this, and a degree of cellular tumor, which as we come into higher magnification, we can see has multiple different cell types. So we see some of these large trophoblastic cells, intermediate trophoblast, some syncytial trophoblast, and the cytotrophoblastic elements here as well. So you get this nice appearance of multiphasic type of morphology, along with the hemorrhage. When you see that, you think choriocarcinoma. But what would this look like if we were looking at a post-curettage sample rather than a metastasis? Well, here's an example for us, and we can see as we come in here that we have a lot of fibrinoid necrosis. We have a little bit of cellular tumor here as well. And as we look at this, we can see that, again, we begin to see this multipartite morphology of different types of cells, a high degree of pleomorphism. We'll go here a little further. Here again, we can see these cytotrophoblastic cells, intermediate trophoblast, admixed with this backdrop of very fibrinoid necrotic tissue. And here you see a little bit of myometrium with the trophoblastic infiltration, some single cell pattern, and here we see it again. So this gives us a little idea of what this looks like in a curettage sample. Fragments, maybe with some admixed myometrium and necrotic tissue, and little islands of highly atypical cells. Now, if we were to go to a resection sample, it might look a little bit more like this. And so we take a look and we can see here we have obvious vascular invasion by this neoplasm with multiple different cell types here again. Variable morphology, those more syncytial trophoblastic type cell, as well as the intermediate trophoblast in quite marked abundance, and here a little bit more as well. As we look at it in a more infiltrative pattern, we can see it involves the vessel wall and is forming this mass of tumor cells, a lot of cytotrophoblastic cells here as well. And so sometimes you'll have one area that may have a predominance of one element over another. And that may make it a little bit difficult if, say, you just had a needle biopsy. But given the history and the markers that you would expect to find, finding this more monomorphous pattern would certainly be compatible with the diagnosis of malignancy. Now let's look at it in another site here. In this situation, actually occurring in the placenta. So this example is, I think, a very interesting one to look at. We see that down here towards the bottom, we have some more normal appearing villi here. And then we have this cellular and more fibrinoid and mass-like area, obviously a different consistency. And as we come into this area at higher magnification, oops, if we can get the magnification go the right direction. We can see the cytomorphology of this tissue is quite different than the surrounding normal villi. We see this marked trophoblastic proliferation, some cytotrophoblast, we see some necrosis, and even here a few multinucleate syncytial trophoblastic elements. So finding this in an intervillous pattern within the placenta would also be diagnostic of choriocarcinoma. Again, this is an unusual finding in my experience and something that we may not encounter in everyday practice. So moving back to kind of the final takeaways from our discussion today, I think there are a couple of things to remember. One is the hormone status can help you. The gross presentation can help you. And using the microscopic features we've talked about here, along with selected immunohistochemistry and potentially cytogenetics, you should be able to come away with a correct diagnosis in these situations. So that concludes our little tutorial on gestational neoplasia. I hope you've enjoyed that little tour. As I've indicated, the slides are available either through the links below or directly to the Rosai Collection, from which I've drawn some of these interesting slides. And so until next time, thanks so much for joining me.